MGH's ICUs are caring for profoundly ill COVID patients who may benefit from extracorporeal membrane oxygenation, or ECMO. The two key patient types to consider are pulmonary, those with profound hypoxia despite heroic treatment measures, for VV ECMO, and cardiac, those who have profound shock from acute heart failure, for VA ECMO. In both conditions, ECMO may serve as their only chance of survival. First, let's look at venous-to-venous ECMO, or VV ECMO. What is it? The best way to think of VV ECMO is as a lung replacement for patients who require nearly total pulmonary support. Who is it for? The sickest COVID patients who, even with ventilator support, continue to become profoundly hypoxic despite increasing pressures and oxygen delivery are candidates. Patients are generally considered if P to F ratios are below 80, if there is respiratory instability with prolonged desaturations, or if there is very poor lung compliance. Patient selection. Even when these criteria are met, not all patients will be good candidates. For ECMO, generally speaking, patients who are younger and are healthier at baseline have the best outcomes with ECMO. More specific criteria or cutoffs will depend heavily on the center and availability of ECMO circuits and teams. The components are a drainage cannula, a pump, membrane oxygenator, return cannula. The device. Here's a close-up of the oxygenator. There are three key control parameters. 1. RPM controls blood flow. 2. FDO2 controls the oxygenation of the blood through the fraction of delivered oxygen. This is like FiO2 in a vent. 3. Sweep represents the fresh gas flow through the oxygenator. This controls CO2 removal. Heat exchangers. You can see heat exchanger units at the bottom which maintain body temperature. So even with sepsis, the patient may remain afebrile. How does it work? The overall goal of venous-venous ECMO is to adequately remove deoxygenated blood from the central circulation and return the oxygenated blood to the right atrium so the heart can deliver it to the systemic circulation. There are multiple ways to accomplish this. In adults with COVID-19 disease, the most common method is to use a percutaneous approach similar to central line placement. Three primary methods are used for percutaneous VV ECMO. Number 1, femoral-femoral. The femoral-femoral or fem-fem bifemoral approach, VV ECMO cannulization configuration, has both the access, drainage, and return cannula inserted via the common femoral veins. Blood is accessed from one cannula positioned in the inferior vena cava or IVC. It's pumped through the oxygenator of the ECMO circuit and returned to the patient at the level of the right atrium via the contralateral femoral vein. This has the advantage of only requiring the lower body to be in the surgical field and keeps the providers away from the patient's airway. 2. Dual lumen internal jugular. A large cannula is placed in the right internal jugular vein. This specialized cannula has drainage ports that are at the distal end, which is in the IVC, and the proximal end, which is in the superior vena cava or SVC. This return port is at the level of the right atrium and is directed across the tricuspid valve. This configuration is ideal for early mobility and it allows for greater flexibility of patient position. However, the cannula can become malpositioned, requiring echocardiography to adjust and would likely increase provider exposure during COVID-19 and is not currently recommended. 3. Femoral to internal jugular. The most common configuration where the drainage cannula is placed in the femoral vein, usually the right, which has a straighter shot, and the return cannula is placed in the internal jugular vein, almost always on the right. This configuration allows for two providers to simultaneously perform cannulation to enhance efficiency in an unstable patient. This is relatively straightforward to place with minimal image guidance. Transthoracic echocardiography is recommended and almost always used at MGH. This usually allows for positioning to minimize recirculation. This is a phenomenon where oxygenated blood is cycled through the ECMO circuit and not through the heart, greatly reducing the efficiency of ECMO to provide support. When initiating ECMO, Be prepared to bolus fluid since patients are almost certainly dry. There is often a contact activation vasodilation. It is transient and responds well to norepinephrine. It's far easier to place lines prior to ECMO, so consider placement of radial artery line, a left IJ or subclavian CVC in advance of the procedure. If any cardiac concerns, consider a PA catheter. It is better to place the cannula slightly too deep and then withdraw than the other way around. It's recommended that ultrasound guidance for placement, transthoracic echocardiography for positioning if able. There is a very low threshold for treating sepsis. It is difficult to swap ECMO cannulae. Central line best practices. It's hard to remove lines, so try and minimize infection risk. That is, draw the lavs off an A line. Here's what the VV ECMO does not do. VV ECMO offers no significant cardiovascular support and does not treat shock. However, quickly reversing acidosis may be of some benefit to the heart, and you may see an improvement in cardiovascular function with a normalization of blood pH. Should the patient suffer a cardiac arrest during the procedure, the VV ECMO could be converted to a VA ECMO, which does provide cardiovascular support. Considerations. VV ECMO requires a large team and presents tremendous clinical challenges, from hemorrhage to sepsis, and is only for carefully selected patients. ECMO is not widely available. However, as COVID continues to have debilitating effects on some younger patients, consideration may be given to expanding its usage. Outcomes. In summary, VV ECMO oxygenates and pre-ventilates the blood before blood enters the lungs from the superior vena cava and is one of the options to consider when oxygenation becomes severely impaired. Some patients have benefited tremendously. Case study. The first reported North American case of VV ECMO for COVID required only 160 hours of ECMO support, with additional treatment targeting hyperinflammation. This young patient had demonstrated rapid and profound respiratory decompensation. Bridge. For VV ECMO in ARDS from COVID-19, the most common plan is bridge to recovery. The feasibility of lung transplantation in this population, if they were unable to be removed from ECMO support, is unclear. There's a separate film on VA ECMO. Thank you for watching.